Hello everybody, welcome to the HSJ Digital Strategy Virtual Summit. My name is Alastair McLellan, I'm the editor of HSJ and I'll be chairing a few sessions during the next 3 days. So I hope you've all watched the introductory video, so I won't repeat my remarks there about how the significance of the last 6 months for the NHS's engagement with digital strategies. But I think it is worth stressing how the enormous amount of change that has happened during the first pandemic peak. And because there's been an enormous amount of change, there has been a lot of comment on what has happened, why it has happened, and what will continue happening. A lot of that has been little more than idle gossip. And what we hope to do in this conference, and particularly in this session, is to drill down and see what has actually been happening on the ground. Now, before we get going, just a few admin notes for you. You can use the virtual lobby area and the navigation bar on the platform to access the program, the delegate list, find out more about information about each of our partners, thanks to WHO for their support, and join each panel session when it's time to go live. You can ask questions via the box by the live panel window. I really encourage you to do that, please. We've got some great panelists here. Take the advantage and ask them some questions. Between sessions, you can leave thoughts and comments in the chat room. We're encouraging people to pick up on the theme that I've just mentioned, which is what is actually going on the ground digitally in the NHS, and how does it sort of compare with the chat around it? Are things happening to the degree that people are? Are they happening differently from the way that it's commonly discussed? For any technical assistance, please use the help desk in the lobby area. Right, we have 4 excellent speakers who I will introduce in turn for this session. Kicking us off is Dr. Ian Denley, who is the Joint Chief Executive for System C and the Chairman of Graphnet Health. Ian, over to you. Ian, I think you've muted. You have to unmute yourself.
Yep, the host had muted me, I'm unmuted. Okay, so I'm going to pick up on that theme just for 5 minutes of what's happening on the ground. So with System C and Graphnet, we've been working really hard with a lot of our customers in the NHS and social care across all our solutions. And I've got a few sort of themes really, I think I'd like to pick up about what's actually happening on the ground. The first theme I think is accelerated deployments. I mean, we've seen customers in the NHS roll out solutions now at a much greater pace than we've ever seen. So particularly mobile, clinical collaboration, electronic ops, patient flow, information sharing, and so on. And we've actually seen thousands of users really onboarded over days rather than months or years. The scale's been quite staggering, really. And of course, what that means now is that users are, we're getting many more users who are seeing the potential of IT to support clinical and operational practice. And I think also the sort of partnership approach between the NHS staff and our staff as a supplier has never been better, really, never been stronger. And there's a huge sense of sort of common purpose, really. The second theme, obviously, given the lockdown and so on, is remote deployments. We've now done all our deployments over the last few months completely remotely, and that includes 3 full EPR deployments with nearly all our staff working from home. Now, obviously, that has its challenges, but it's also brought some really positive changes. So, for instance, clinical input has been amazing, with large numbers of clinicians who are very happy to jump on a short Teams call to provide input or insight. In a way, perhaps it was harder to engage when we were traveling to site and trying to marshal them towards meetings. So I think clinical engagement has really taken off actually as a result of the pandemic. The third theme I think we've seen is accelerated innovation. So customers have been approaching us all the time with problems to solve and ideas that they want to put forward for us to develop quickly. And more importantly, probably a genuine desire to work with us to crash through barriers, to make things happen in the shortest possible time frame. So there've been lots of important innovations. I'll pick out one which is around the use of data, particularly the use of what you might think of as population health data, but let's call it direct care analytics, where we've worked with customers to aggregate lots of new data sets in short order, deployed dashboards to show how COVID is affecting the health and well-being of local communities and what services need to be in place. And that work has really been done at speed and with a tremendous partnership across the NHS and with social care. We've also seen work now going on about getting patients involved more and developing things like care at home solutions and so on. So lots of innovation, lots of ideas coming from the NHS to us as suppliers. And then I think finally the fourth theme really is a lot of emphasis on keeping frontline staff safe. That's been a massive emphasis for customers. So, and that's used technology in quite novel ways. Lots of our customers have been rolling out electronic handovers, really good for teams with high staff rotation, really good for making sure that people don't need to meet face to face, very good for keeping paper out of the process, and obviously for continuity of care as well. Lots of work going on using secure messaging, patient identifiable data, photographs and so on to get advice from remote consultants, which means staff don't have to meet face to face and don and off PPE all the time. And then finally, I think lots of NHS staff are working from home, either due to illness or self-isolation. And again, we're seeing technology being used in novel ways. For instance, we've got one customer with doing all microbiology referrals from home using our mobile apps, accepting only e-referrals, and that's being extended now into other services like critical care outreach and so on. So those are kind of the four themes I think that I'd like to talk about. But just to end, I've kind of concentrated on what's been achieved, but I think as ever, it's the people that have brought about these changes, often in the face of personal or professional challenges on both the NHS and the supplier side. And I think my big takeaway is it's people that's driving the technology rather than vice versa at the moment in the service. And I hope that it stays that way going forward. That's all from me.
Thank you, Ian. Yes, well, it's been a common theme of conferences of this kind before the pandemic, that actually with the cultural challenges around IT implementation, which were often the biggest barrier to innovation, introduction of new technologies. And it's very interesting, this sort of natural experiment that is going on at the moment seems to be proving that point. Right, our next speaker may well have some views on that. Simon Weldon, Group Chief Executive for Northampton and Kettering General Hospitals. Simon.
Thanks, Alastair, and good to be here this morning. So I'm going to share an unashamedly operational journey for you this morning and give you a take on what we've been through. Before I go any further, I really want to just pay tribute to all of the staff who've made this happen. Ian's exactly right, of course. It's the people who make this happen. And we wouldn't be where we are today without the enthusiastic adoption of what I'm about to share with you. So we started out as in Kettering wanting to get better at being digital, and we partnered with System C to do that. The reason for that, if I ever needed reminding, I just need to look at that picture on the right-hand side of the screen there. That is pretty typical of what I faced every day when I went into work, and it was clearly something that we needed to address. So we'd set ourselves a long-term ambition about becoming the most digital hospital group in England. and we were making good progress on that. So you can see some of the things that we had got on to have done by then. So we'd changed our theatre systems, we'd implemented Vitals, we'd used Connect, we'd started using non-urgent electronic referrals, and then COVID hit us in March 2020. And I want to share, I suppose, some of the things that happened, and this is the first one of these things. So in part, the first stage was an entirely operational one, and you can see here some of the operational things that we did and how quickly we did them. From the 9th to the 1st, so this is from the 9th of March to the 1st of July. And I suppose my first key takeaway is, never have I seen personally such change go at such speed and with such success as we saw here. We went from virtually having no Teams to just under 3,000 devices enabled with Teams, 176 Teams created, 10,000 maximum users. All wards were enabled for patient and relative video calls, and then we enabled virtual consultations. So a colossal amount of change, and all achieved quietly in the background, but really making a difference to both patients and staff. We also did quite a lot of stuff in terms of the technology and giving people the right to work from home. And as we went into this for a bit longer, I suppose one of my first key messages is, this is now the new normal. I think staff are expecting, as we go into wave 2 of COVID, however that plays out, that this is now the new normal. And I think it's going to pose us some fundamental changes as we look forward to what the people plan challenges us to do about how do we make a different offer to staff. I think people will now want to work far more mobily as the new normal. And we've got more plans to deal with this as we go into wave 2 of COVID, further expansion of what I have said here. So first key message from me is massive adoption of the technology, done with almost no breakages, no issues in terms of delivery of that technology, and a real challenge for us now to think about how do we make this the new normal. The other thing we did was, of course, we still continued to progress our digital program, because the second key takeaway from me was, it wasn't just now a nice to have, it was an absolute must do. In other words, we couldn't really respond as effectively to COVID as we would like unless we did some of the things that we did here. So we began to accelerate some of the things that we were doing in our digital program, precisely because of the COVID challenge that we faced. And you can see some of those things here. And I believe that, you know, now healthcare is so complicated and the needs of patients so complex, both before, during and after they stay with us in hospital, that this is now not just a nice to have, it is a must do. And we will plan to go further with this, as I'll show in a couple of slides' time. But here, if you wanted evidence of that, is a quote from the front line. It's not now, as I said, just a nice to do, it's a must have. It facilitated team handovers by providing up-to-date clinical summaries that are accessible away from the bed space for all our patients. Information stays relevant and concise, allowing for good situational awareness at a difficult time. When we are stressed in terms of the numbers of staff that we can deploy, we need to know, frankly, who the sickest patients are. And in just a period of a couple of months, moving from an entirely paper-based handover system to an entirely electronic handover system makes the difference that allows us to do better for our patients and make our staff feel safer. Here just is a couple of other thoughts about it, again from staff. These are real life quotes from people who 6 months ago were not using this technology at all. And one of the key things here for me, kind of the third key takeaway, is None of this was done with resistance. We often hear about some of the disasters that happen around IT. I can say without qualification or fear of contradiction that our staff have loved doing this, as you can see, love the multimedia aspect with pictures. And you can see that a few things, I think, were enablers to that. We stopped other things, so we accelerated our IT on the left. We were the first ward in the country to go live with MedWave Flow, and whiteboards will never look the same again. We brought staff in, so we changed the way we worked, we changed the staffing model, we brought more people in to support what we were doing. And relentlessly, we went for agile ways of working. And finally, of course, our journey continues. There are huge amounts more that we still have to do. This is about the very best in terms of partnership with our staff, partnership with our patients, as you can see, where we move into the kind of Q2 to 4, and partnership with obviously System C. Together, we have made a real difference, and I'm confident that we face wave 2 of COVID and the winter in a better place than we did before we would have done 6 months ago. So thanks again to our staff and to our partners for all that they've done. Thanks, Alastair.
Thank you, Simon. Right, time now for a report from the very front line of the COVID second wave. Let's hear from Christine Waters, Director of Informatics at St Helens and Knowsley Hospitals, NHS Trust. Christine.
Thank you, Alastair. Good morning, everyone.
Christine, I don't know if you've muted yourself.
No, I think it's the system. I think we're okay now. Great.
We are.
So, yeah, great. Good morning. I'm Christine Walters. I'm the Director of Informatics at St Helens and Knowsley Hospitals. I actually sit on the Trust board, but I also head up a shared service which actually provides IT services to all of Mid-Mersey, which is part of the Liverpool City region. So we are the first region from Wednesday to go into Tier 3 level lockdown. So we're not facing wave 2. We absolutely are in wave 2. So I'd actually like to start by reading an email that was sent to my chief exec from one of the consultant initiatives in March, just to set the scene of what it was like, both from a clinical and then from a technology point of view. So Anne, who's my chief exec, has very kindly said I can share some of this. So if you can remember, on the 30th of March, we're here in the Northwest. We'd seen what was happening in Italy. We'd seen what was happening in Spain. We could see what was happening in London. And to say we were scared is putting it mildly. From the top of the organisation down to the bottom, we were anxious, we were worried. We did not know what was coming, but we knew it was going to be very, very scary. So at 4:45 in the morning on a Sunday, this email popped into my boss's inbox, and it said, "Dear Anne, I'm just finishing the weekend night shifts, and we've had an unprecedented number of cases who we've had to intubate and ventilate on ITU. The COVID bomb has well and truly exploded at Wiston this weekend. We have worked above and beyond our capacity. The ODPs and recovery nurses have been thrown into the deep end and have suddenly become ITU nurses without any formal training. Everyone is working as a single team despite dealing with the disease that can potentially take away our lives. I'm sure you will be proud of how we have dealt with the crisis this weekend, and I promise we will keep fighting the onslaught. I thought I should let you know as our chief exec because I'm exhausted, anxious, yet humbled by the way the staff are working." And Anne, I'm just going to read a little bit of a snippet of one.
I'm hoping somebody can fix this soon. Is it muted?
Okay, I don't know what to say, sorry. I am truly in awe at the sheer selflessness, dedication and professionalism of our staff at this terrible time. What you are having to contend with is totally unprecedented. I could not be more proud or more grateful. And I have to say, I couldn't be more proud to be a member of the board at this hospital, and I couldn't be more proud of the way my team responded. People, many of them had to be dispatched to home. Many of my team had to change the roles, jumping from IG onto the help desk, for example. And many of my staff worked through the night and worked for days. And we weren't just supporting the hospital, we were supporting primary care, mental health, community, the works. And just some of the things we did. So my team in over 2 weeks deployed, got over 3,000 staff working from home. They rolled out 1,400 laptops and PCs. They rolled out video technology so relatives could speak to their sick ones in the hospital and could have virtual appointments. We deployed 2,300 VPN licenses so people could use their own equipment at home and still be able to work and contact within their IT systems. We rolled out over 2,200 webcams and headsets, and that is just a small flavour of what we did. It was absolutely phenomenal the way my team worked, and I'm humbled by the way my team and my colleagues in the hospital responded to Wave 1. It was quite staggering. We learnt so much from a digital point of view, and what is clear, if things work for people and make things better, they'll use them. However, the technology we put out in Wave 1 is not good enough for Wave 2. We're not facing Wave 2, we are in Wave 2, and we have to learn from what we've done. And so the scale of pace of change is still ongoing in all the organisations we look after. So for example, we rolled out Skype for Business to 14,500 users. It wasn't good enough. It was the best that we had. We're now replacing it with Teams, which will be completely rolled out by the end of this month. So we are absolutely having to continue and push. Wave 2 isn't like Wave 1. The requirements are different. We've got great foundations from Wave 1 technology-wise, but it's not good enough. The performance isn't good enough, the usability isn't good enough. So there's much more that we've got to manage to address in a really short space of time. So on that note, I shall finish other than to say I'm very proud to work for the NHS, I'm very proud to work for the STHK, and I know that we will get through Wave 2, but I also know Wave 2 is going to be much more challenging and very different from Wave 1. Thank you, Alastair.
Thank you, Christine. Last of all in this session, but definitely not least, we have Tara Donnelly, Chief Digital Officer for NHSX. Tara.
Thanks very much, Alastair. And I might just, before I kick off, just share a few observations and reflections really from the first three speakers, because I thought there were some very consistent themes there. The first one being about common purpose, about this extraordinary response we've seen from staff, and that extending absolutely to partners in technology, that we've seen collaboration like never before, and that's one of the things we want to keep going. That theme of accelerating that we heard from all three speakers, getting things done in days rather than months and years. And then finally, that point about the new normal and working really quite differently. I thought those were really powerfully made by the three speakers before me. To say a little bit from my perspective, and I'm Chief Digital Officer at NHSX, and just to explain what that seeks to do, it seeks to digitise, connect and transform health and care. And the first wave of the coronavirus outbreak really was quite an exceptional time for digital health in this country. It was obviously awful for so many reasons, but we did see some of those barriers that we've talked about at length for many years just disappear in terms of the speed of getting things done. And we also saw citizens as well as staff embrace technology like never before. I mean, people were extraordinarily accommodating, and we saw things like the numbers of video consults just go through the roof. We had small British startups developing products over weekends that were deployed across millions of people, incredible scale. Accurix would be a case in point. We couldn't have achieved the huge transformation in primary care without that one little startup. We had some of the bigger tech providers doing things like providing free Facebook portals to care homes. And we had people like the telecos who sped up bandwidth for clinicians working from home. Really quite incredible to see such a response from such different parts of the kind of health tech community. One of the one of the things that we got involved in is that we were approached by a clinician from Watford General Hospital who had a huge virtual ward, which they were managing with Excel and phone calls, and asking was there any technology that could help. And we were able to broker from one of the offers that we received. We received nearly 1,000 offers, some pro bono help to set up tech-supported COVID monitoring at home. That gentleman was Dr. Matthew Knight, and at the weekend he was recognised at the Queen's Birthday Honours for the work that he has done. We found that work absolutely fascinating, to have people who are leaving hospital much earlier than previously, responding, taking their symptoms and their pulse oximeter score, sticking it in an app, seeing the double ticks when a clinician has looked at them, which they found incredibly reassuring, and their information being put on a dashboard at the hospital end. Incredibly time-saving for staff. Instead of phoning lots of people who are well, they could focus their attention on the much smaller group who are deteriorating. And one of our offers from NHSX is we would love to work with anybody who'd like to put one of these in for second wave. We think the impact is really significant. In terms of time saving, it looks at the acute hospital model to be about 32 minutes per clinician per day of patient that they're looking after. A bit less in primary care, but still a great use of quite simple technology to help track people remotely. The model can obviously also be used in the longer term for remote monitoring for long-term conditions, but right at the moment that focus on second wave means that that's particularly where we're supporting and helping people. So if people want to make contact after this, I'd be absolutely delighted to pick up on that further. And I'll stop because our time here is brief and we leave a bit more time then for questions, but they were just some of my perspectives and an offer really to those on this call. If you'd like to introduce home monitoring for COVID, whether out of a primary care hub or an acute hospital, we'd love to help you. We'd like to accelerate that work by the end of December to have many more sites doing what they've been doing in Watford. Thank you.
Thank you, Tara. Right, ladies and gentlemen, my Q&A box has nothing in it, so please fill it up as quickly as you can. Don't worry, I've got a few moments because I've got quite a few questions to ask myself. Christine, I want to come back to you as the person who is dealing with the most immediate and pressing problems. You talked about two things particularly. One is how the second wave was different and harder than the first wave. I'm assuming, please correct me if I'm wrong, that it's harder because you're having to deliver electives and cancer care and emergency care demand on top of dealing with COVID, which wasn't the case in the first wave where everything was pretty much stopped. You also talked about the tech not being good enough, and you gave one illustration. I wonder if I could ask you to expand on both of those areas. The different set of challenges that the second wave is posting, and how they require different technological digital solutions than those applied in the first wave. Can I ask you to expand on that, please?
Yes, certainly. So we supported in the first wave getting lots of people be able to work from home and to work safely. And we're having to do the same again. But last time, as you say, we didn't have elective care. So as we converted wards to critical care areas and we converted wards to COVID wards, which we've already done in my hospital, and my hospital was on the BBC News last night, that was the hospital that we're talking about. This time, we've still got to continue elective care. So last time when we were shipping and moving loads of equipment around, because we have to be extra careful around infection control, we just move kit around from different, that's not possible this time. So now we've got to find more kit, but we're also finding, like with Kettering, with Simon, we're using the same products from System C. We're at different stages of the journey, but what we are moving towards is trying to go paper free as much as we can. We've set up CPAT areas. We've never had those before. We didn't have those at the start of wave 1. We've now absolutely got CPAT areas at the start of wave 2. They want to work in a very different way. So we're moving forward with them. We're giving them Careflow Connect and Vital so they can go completely paper free and do it in a safe way. We've also got primary care that I look after. Now, We've got practices closing all over the place at Merseyside because they've got such a spread of the virus. We didn't have that last time. Last time, clinicians moved and did a lot of remote working, but practices on the whole kept working. Again, it brings very different demands and very different responses. People were patient first time. If things were a bit slow when they were working at home, they put up with it for a while. But when you've been at home for 6 months, which many of our staff have, that performance level isn't acceptable. So we're bringing in virtual environments, we're improving our VPN offering, we're improving our network offering. It's a massive amount of work going on by my team to try and make sure we give systems are absolutely fit for purpose and help to keep the clinicians and patients safe and able to have that information accessible when they need it.
Thank you. Simon, let me come to you now and ask the same question. What things are different about the second wave which require a different digital solution? Things that might have worked in wave one, but require a different approach or a different set of solutions during wave two?
I think probably for me, the biggest one is the link up with social care. So if you look at the things that we managed to achieve, we largely transformed the way the NHS worked within its own boundaries. All of us, I think, many hospitals up and down the country really shifted the dial on that. For me, the dog that didn't bark was how do we create that same momentum, that same transformation in social care? Because many of the most difficult interfaces that we had were on discharging patients safely and successfully. So some of the things that...
do you have an answer? Sorry, so do you have an answer to that question? Is it an unanswered question, or are you in the process of answering it?
I would say it's very much a work in progress, Alastair. So I think that the first answer, which I've asked my team to explore, is how do we make social care staff trusted users of our data? So we've had up until now traditionally very sort of, even within the systems that we've got, which absolutely are not interoperable at the moment, we've had no access. And I think the first thing we have to do is to say, look, for those patients who are on a list to be discharged and who are in a social care assessment, something we can, with our products, highlight and isolate. Why would social care staff not have access to their data so we can start to pull patients out of hospital as opposed to push? The bit that I don't have an answer to, of course, is how do we extend that beyond the hospital borders so that caseloads that are happening in care home settings where there may be clinical risks are much more shared with us. So that for me is about the shared care record, and that's probably the big unexplored frontier. All of us talk about the shared care record in quite hushed tones as though it's this kind of grail-like goal. But in actual fact, that's the thing that if we're going to provide truly systematic care, we've got to accelerate, and the place that I feel we still haven't made the progress we can or should.
Okay, thank you. I want to ask Ian the same question, and then Tara, I'm going to come to you last for a sort of national picture about the different nature of the second wave. So Ian, what are your clients telling you about what they need for the second wave that is different from the first wave, and how are you going about helping to meet that?
Okay, so I think from our perspective, I probably agree with Simon actually. There's a massive push at the moment. A lot of work that we've done within the acute sector, you know, that's been rolling out very quickly. The big push at the moment is around the shared care record and how we join up all the different silos of information. And Graphnet have been, you know, working very hard at that, and there's a lot of emphasis behind that. The other thing I think is off the back of the shared record, once we've assembled all those data sources, we're able to start using that data for direct care analytics, and we've seen a real pull from the NHS to start exploring that data. We've done a lot with cohort mapping so that we can look at different different cohorts of patients. So that targeting of care is definitely ramping up in the second phase, and that's partly driven by all the learnings of the first phase in terms of you know, the vulnerable groups, the greater understanding of the vulnerable groups that we've seen, and then being able to use the data to drive down services targeted at those vulnerable groups. So that's quite a different way of working, I think, second time around. I think one thing I would mention as well, probably, we've all got staff now working at home, both on the NHS and the supplier side. And I think this time around, the sort of pastoral care, if you like, of our staff is really important, because I think, you know, for 3 or 4 months, people have kind of got used to the idea of working at home. It's not as easy as one might think for lots of people. We've now got, you know, another 6 months at least of that. And I'd say that that's an important shift for all of us, really, in terms of looking after the mental and physical well-being of our staff as well. I think that's changed. That's ramping up for sure. Okay,
thank you, Ian. So Tara, I'm sure the list of things that NHSX, along with E&I, looking at for the second wave is very long. But can you pick out perhaps the 2 or 3 things where maximum effort and attention is going on at the moment to make sure that the NHS responds as well as possible to the second wave?
Sure. So, and I think just looking at first wave, second wave, I think one of the issues around first wave was we had to experiment a bit, and we have now got a bit more evidence and information about what makes the biggest difference. I completely agree with Simon's point about social care, connecting with social care and having information flowing between care homes and hospitals in particular. You'll have seen the story about us buying 11,000 iPads for care homes. That's on a pull basis, so care homes need to request them, and in the first 10 days we had 8,000 care homes asking for them. They're SIM enabled to kind of cut through the issues around Wi-Fi. And they will have the summary care record app on it, so it will have people's basic information, at least, between hospitals and care homes. That in itself will make a big difference. Apart from anything else, it will enable all of those care homes to fully participate in the virtual ward rounds that GPs have been offering people who live at home. So it's making sure that just because someone lives in a care home and 410,000 people spend their life in a care home, they're not treated, you know, they get as much access to healthcare as you would if you were at home. So that is a big push. We're calling it joining up care. It does increase the ambition of the joined up care records across the country, but a real focus on how can we help tactically care homes manage the second wave differently from the first time around.
So that's something you've done. Is there what's the sort of next thing on the list that you now have to fix, because it will of course be a rolling?
So it hasn't been done. The money's been obtained, the devices have been purchased, they're just starting to go out to organisations. They'll have quite a lot of support with that, so we'll see that continuing to build over the winter. The other point was the one I made before about the offer to the system. We'd love to get maybe 20, maybe more sites running this COVID at home model. Great in terms of capacity help during the winter. We want elective surgery, particularly urgent cancer surgery, etc., to continue. But if hospitals are completely full, they'll be unable to do that. So that's another big part of our current offer.
And somebody asked Tara if you could repeat the name of the software for this primary secondary monitoring container.
Yes, so people can use, we've just done a we've just done a procurement exercise over 4 months. So on the NHSX website is a whole list of suppliers who've made it through that process. The original one we used pro bono offer from Medopad, now Huma, but it's a great mature part of the marketplace. So there are lots of systems that can use either a patient portal or a platform to simply convey those results to a clinician. So you may have technology you can already use, and if you don't, do have a look at the list. There's a little microsite on the NHSX website, and we'd be happy to hold your hand through that process. We've got some support from the procurement hub to do that and to help anybody interested, so please do get in touch.
Right, some good, nice, pithy questions coming in, so I'm going to bang through them as quickly as possible. Tara, any future thoughts about the future funding of Accurex in primary care? This is why this may stop in April without national funding.
Yeah, that's not an NHSX That's the primary care team in England are looking at that, and I don't know what the latest is.
Okay, thank you very much. Christine, a question for you. The St Helens Care Partnership shared care record, how has that worked, and how has it has that made a difference to your COVID response? Has it done what you wanted to do?
So I tried to put my hand up. We are very fortunate. We have a shared care record, but only for the borough of St Helens, and we look after a lot wider footprint than that. And actually our shared care record, it is actually a Graphnet solution. It is actually a core and essential tool, and it's used by social care, the voluntary sector, the hospital, community, GPs, and it has absolutely massively transformed the way we provide care to the citizens of St Helens. It's a tool that when I talk to GPs or pharmacists, whoever, they all say it's something they could not imagine being able to do their jobs without it. And during wave one, it made a massive difference to us, and being able to work in multidisciplinary teams, and particularly with supporting care homes. So absolutely, it's fully embedded and utilised in St Helens. What we also did as part of wave one, we did actually take the population health management BI module from Graphnet, and we managed to roll it out in a 6-week period, which is absolutely incredible. We wouldn't even, normally you'd spend even more than that amount of time just talking about it. We are now have our COVID dashboards. So my favourite GP is Dr. Lawson, who's a fantastic supporter. He can able to go in and look at his own patients to see in his own practice which streets are the hot spots. He can see which patients have had COVID, who are waiting for tests. All that information is available to help him manage and look after those most vulnerable patients. And that same information, when those patients come in to hospital, is available to the clinicians in the hospital. So it's an absolutely essential tool, and it will make a massive difference to us in wave 2 as it did in wave 1.
Simon, I wanted to ask you a question about the sort of reality of running a big acute trust group in your case, where the nature is that you've got a whole range of professional tribes, all wanting to, quite rightly, promote their particular interests. I think we saw during the first wave a lot of that healthy competition set aside to deal with the emergency. But now, of course, it's a very different matter, because cancer is back going again, and all the different types of cancer are back going again, and all the issues about shared resources, etc., are once again live alongside the challenges for COVID. So whereas I imagine during the first wave there was a lot of just, the peer pressure was, well, just get on with it. I imagine now that it's slightly, it is quite different, and I wonder how you as a chief executive are handling those tensions in a way that are different from the the way you handled it in the first wave.
So I think there are 2 points I'd make. The first is around the premium that is now required around information and the ability to analyse what is going on in the organisation. So you're quite right, Alastair. If you like, wave 1 was the easy part of the job. Wave 2 is 10 times harder, because you've got staff exhaustion, you've got elective recovery, you've got winter, and you've got COVID all happening at the same time. One of the challenges I'm facing and really trying to grapple with is, how do we know really accurately what is going on in the hospital in terms of the throughput, and what resources we have available to us, what are fully utilised? And we are still in a kind of pre-COVID age, I think, largely in terms of our ability to describe the performance of the hospital. But if you look at the phase 3 letter and all the challenges that set out, that also implied a much bigger challenge in terms of the ability of hospitals to really know on any given day, almost down to an hour, what the performance of the hospital was. I don't mean in terms of, are we hitting a 4-hour or a 52-week target? I mean what I call the throughput variables. And one of the things I'm working on most hard at the moment is developing that kind of dashboard capability. And I do think there's a huge opportunity for us to work much more collectively together to get some of those common data analytical tools at a much greater level of spread. And of course, what I've just said that applies for the group, and it absolutely is now being developed at the group, also applies at the system. So even if we are able to describe what we are doing at a group level, we also now have to embrace the independent sector, what's going on in primary care, what's going on in social care, and understand that resource utilisation much better. I suspect there's probably still opportunity in our systems to do better if we were stronger in that place.
And Tara, let me come to you. I mean, that I'm glad Simon answered the question that way, because that's very much what was in my mind, is that the challenge for this winter is for the NHS to get up to those kind of recovery levels, as well as dealing with the COVID second wave, and a lot of that will be so therefore there's a need to know how well the NHS is doing. Perhaps the centre might not want to know how well the NHS is doing, because then it doesn't get asked all the good questions about it. But are the systems in place for integrated care systems, so the regional way of the NHS operating, and the national way of it? Are the systems in place to know how well the recovery is going, and to know how well to know where the systems can help each other? Because I'm very much mindful of the fact that, you know, they're cancelling operations right now in Liverpool and elsewhere, and, you know, there may be capacity elsewhere nearby that could be used. But you've got to know that performance challenge is going on, and that requires effective and joined up systems. Is the NHS in the place it needs to be able to make sure that the recovery continues at the maximum possible rate despite the return of COVID? And if not, what needs to happen?
I think that we're quite a long way off having a real-time, at-a-glance performance dashboard for the whole NHS. I think certain parts of the country are closer to that than others. There's a tool called Transforming Systems that has done that for years for emergency activity. It's just developed by working with one of the regions, an elective part of that component to try and build just that. But I think an awful lot of the information that is put together at the moment is done through quite labour-intensive manual returns, which creates quite a burden at trust and CCG level. So I think we're quite far from that, with exceptions.
And so therefore, is that a priority over the winter, to try and get the NHS up to that level where it doesn't have a complete picture, has a much better picture of what's going on?
Yeah, and I think there was some valuable work done in first wave, looking at the kind of highest priority. At that point, it was looking at ITU capacity across the country, and some nice use of data. Indra Joshi led that work in the AI lab. And they're certainly looking at, are there other things across winter that could help like that? But it's difficult to imagine it being a kind of overnight fix. But I totally agree. We need to, you know, just as we've managed to provide for clinicians a dashboard so they can focus on the 8 patients who are unwell and not the 170 who are progressing fine, we need to do the same for chief execs and CIOs and board members. I feel the pain, having been one.
Thank you, Tara. So, Ian, I'm going to give you the honour of the last word. I'm wondering, you're in a position like Tara, where you see what's happening across a range of organisations. What are the kind of behaviours and approaches that are meaning people are getting things done well and quickly, and the kind of behaviours that you see where people are perhaps struggling? You don't need to name names, but just give us a sense of the kind of, you know, if there are chief executives, etc., watching here, what kind of things gets the job done, and what kind of thing gets in the way?
Okay, so what kind of thing gets the job done? I think is when you're working with partners who can work in an agile way. So you know, with the two trusts that are here today, I'd say the partnership is really top notch. So we work together, we take requirements, we build things very quickly, and we get them deployed into live very quickly. So we don't make the perfect the enemy of the good. And then that allows you to then build on that and keep extending it. So it's proper agile working that drives you forward. That doesn't mean you're not paying attention to clinical safety and all those things, but you're actually you've got a genuine desire to incrementally develop things that work and fail fast on things that don't. I think the things that get in the way sometimes is I think perhaps in the past some trusts, some departments have grown quite used to things moving quite slowly. So IG issues may take 6 months or a year to sort out, and some places are still in that mindset. Now that doesn't mean we've thrown caution to the wind on IG. It just means that actually people have focused very quickly on how to solve IG issues. But I think perhaps a slightly older mindset exists in some places, but in many places that's moved completely now.
Okay, thank you very much. Yes, with Sarah Wilkinson from NHS Digital. We did a story on her today about the NHS's reliance on copy-notices to deal with IG problems and how that is not a sustainable problem. Right, sustainable solution, sorry. Right, ladies and gentlemen, we are now out of time. Can I thank our panellists? Really great kick-off. Thank you to all. Particularly good luck to Christine and her colleagues in the Northwest. You have our thoughts and prayers. Okay, ladies and gentlemen, that's this session done. The next session on data and delivering actionable insights to improve patient outcomes begins at 10:35. I will see you later in the day. Thanks very much.
Thank you. Bye-bye.
Hello.